topic for today is veneer restorations. And I'll change a little bit the style. I'll just pick up one case and follow step by step. Focus on clinical steps, how the dentist should do, or the best way that you should treat the patient for this kind of restoration. When I think about any kind of restoration, any, being direct or indirect restoration, we think in two things initially before we start: the structure that we have it and the material that we're going to work with, being ceramic or composite resin. Thinking in this way, I will share for you 10 steps clinical protocol. Of course, prosthodontics is not just 10 steps protocol, but for make it clear for the understanding, I will share it in 10 steps. Let's understand a little bit about longevity and what the literature tells us about how does it last. There are 3 articles that I would like to mention. This is the first article from Dr. Pumas. It's a very interesting article that the failure rates increased after 10 years. At 5 years, he got like 92% success, but dropped almost half after 10 years. But what's important is the first topic here. The adhesion in dentin and large composite restoration means that you are going to have more failures. If you go to the literature, try to find more topics about bonding in veneers, you see that when you have bonding to dentin and old composite restoration, your success rates drop. Let's see another article published in 2000, 10-year success rate. Same thing. The failures indicate that the connection of the resin cement to dentin may be the weakest link. So if you go further, more recent article, very interesting article, because it was done by just one clinician. Dr. Fradiani did all the preparation. So he stick on a protocol, and he got a high success rate, but also the failures also when it was bonded to dentin. So when you see now the increasing, the patient asking more for aesthetic restoration, and sometimes the restorative dentistry try to do it, but not with the right connection. We have to understand that to have success in veneers, we try to keep our preparation in enamel as much as possible. And I will show to you how to do it, or how to try to do it. And also, understand the bonding procedures. Understand how bonding works or does not work. Let's understand also, it was really impressive, the quality. Don't forget about occlusion. Don't forget about periodontal evaluation, okay? The patient that I'm going to show to you, has a stable occlusion. It's health in a periodontal point of view. And let's go to the clinical steps. The first thing that every restorative dentistry or every clinician must have is a nice camera. Dr. Ed McLaren gave an excellent workshop yesterday showing how important is dental photography today. Not on legal aspects, but also as a professor for ourselves. Because when you take pictures, we see what you do right and wrong. But you have to learn how to do it, okay? So, at the beginning, we took some picture. This man is a model. He's 27 years. He has a stable posterior occlusion and asking us to close his diastema. You see that checking the smile line, it's an average smile line, but when you retract the lips, you see that probably he has too much tissue, that we can do a plastic surgery. Sorry, a plastic periodontal surgery. So we check it, we do the probing, checking everything, checking the x-ray, and you go for a perio procedure. We check, it's possible to see that probably this patient has some enamel that's below this gingiva. After a clear protocol, we anesthetize the patient and we did the surgery. First, we do the design of the gingiva. Then we start to remove this tissue very gentle. See how much enamel do you have. Then we raise the flap and check to establish a new biological width. So we go for around 3 millimeters from the CEJ. We did the osteotomy, and we do as a finishing procedure, removing the part of the bone, keeping the structure of the bone to maintain the papilla and the soft tissue. So you go there, suture. 10 days after, we remove the suture, and here is the result. But when we touch the bone, we wait at least 3 months. We did not touch the interproximal bone, just the facial bone. And you see that we have enamel, and now we are going to the restorative part. We do the same protocol at the beginning of the treatment and then after the surgery, after the healing period. So the first is pictures, control of everything, checking the occlusion, and now we're going to the wax-up. The wax-up that we did in this case was an addictive wax-up. Do not prepare the model, just adding, okay? Just adding. And you see that we need to cut some enamel to do it. But if you just prep the tooth, we are going to remove too much enamel. So we did silicone guides. So we go for picture, additive wax-up, silicone guides. Basically work with 3 kinds of silicone guides. We duplicate the model of the wax-up, and we try and check it before the patients come to your office. And it's possible to see that even with the wax-up, we need to prep. We need to prep in the interproximal area. Patient with diastema, we have to be very conservative in this preparation. And it's possible because it's plenty of enamel available for us. We check it before we prep it every single tooth. Look at that. Okay. And you see that's possible that, okay, I have to cut a little bit here, cut a little bit here. Here I have space, but due to the emergence profile of the tooth, I have to reduce a little bit the interproximal area. And then the second silicone guide is the incisal guide. You see that even adding, we are almost there, but we need to reduce at least 1 millimeter here to have 1.5 to 2 millimeters in the incisal edge. We go to the mouth and we check the guide again, and you see that you have the same thing that we had before in the lab. We check again. And at this time, you have to be very carefully, and you have to have contact with your technician or your ceramist to know which ceramic he's going or she's going to work with. In this case, a recommendation is to have a ceramic that can be bonded, a glass ceramic or an injectable or pressed ceramic. So let's go to the preparations after we checked all the silicone guides. These are the very interesting data. Most of the dentistry does not know how much enamel or what's the distance from the facial enamel to the pulp. If you go to traditional preparation and reduce 1.7 to 2 millimeters of a central incisor, for example, you are less than half millimeter from the pulp. That's why, old time ago, when we did not have bonding procedures, we had to do endo in every crown that we made. But now we can do it with most conservative way. So keep this is the reference. It's an old reference from almost the end of the 80s. It's published in New Zealand Dental Journal. So we have around 0.7 millimeters of enamel, not more than that. And remember at the beginning of the lecture, we need enamel for bonding. So we go for the prep, following the silicone guides. Always, it's my opinion, when we have to close diastema, see the emergence profile, we have to come with a little burr and remove, otherwise you don't have the path of insertion of the veneer, okay? Not all the time we do it, but when we have diastema for veneers, we should do it. Make it very easy for the lab to do the work. Then we go to a facial reduction. How thick should you do that? I don't like that step burrs. I prefer to control the burrs with 2 millimeters diameter burrs. Because when you go with 2 millimeters diameter burrs, we are cutting half millimeter. Because you have 2 millimeters here, 1 millimeters here, so just cutting half millimeter each side. So we have 0.5 millimeters for our veneers. So we reduce just half of this burr, we can say that, and then we go for the regular preparation before and after. See, that is very simple preparation, just removing a little bit this enamel, but always keep the control with the silicone guide. See, when I speak with my students, I always say, do one tooth each time. Do one tooth, put the guide in the mouth, check the prep. Then you go and return to do the other. And always checking. The periodontal probe is the tool that I prefer because it's easy, it's every day there. We check it before, okay, we have almost 1 millimeter. Then we do the prep on 4 veneers. And always finishing the prep with a multiplicator. This is T2 from Sirona, rotating instrument for finishing the margin. We remove all the sharp edges, keeping around preparation. Then we check all the silicone guides. See that you have a clear space here. For the emergence profile, we have almost 2 millimeters here, a little bit more, but we are in enamel. But sometimes we have denting exposure. See that here. We have enamel on the margin, but we have denting over here. Enamel, but what about this denting? At the beginning of the lecture, I've mentioned denting is a problem for veneer. So we have to try to protect it to achieve a better bonding stability. The technique that I use from 10 years now is called immediate denting sealing. This technique has become very famous in the Pascal Money book. But if you go to the literature, you find the same technique named dual bonding technique that's back from the 90s. Was the same procedure intended to protect denting. And if you go to Japan, they do it more than 10 years ago. It's called the resin coating technique. So if you go to the literature, you will find 3 kinds of descriptions, 3 different techniques. But the intention is the same, protect denting when we have denting exposure. And how do I do it? We published this article in Dental Materials. We did everything with acid etch technique. But if I do recommend it for you, I would recommend another adhesive system. Let's try to work with self-etching primer, but not 1 bottle self-etching. Let's work with 2 bottles self-etching. Here's an image of the clear fuel SC bond. See, this is natural denting just after prepared with phosphoric acid etching and with self-etching primer. See the difference? It's much more conservative. And we are close to the pulp. It's very important. Very important to preserve and avoid acid etch technique. So how do I do now for 10 years? I started this technique in 1997, and I do it in every vital tooth that I prepare, every. If I am indenting, I do this technique. So always, for example, this is a crown, but it's the same for veneers. Respecting the final contour, always based on the wax up. Clean with pomace and chlorhexidine gel. Avoid saliva contamination. Remember, the prepared denting, you are going to achieve the best bonding instead of have a contamination. Avoid acid etching. Prefer denting adhesive with 2 steps. We can use, I do work with clear fuel a lot. It's from Curarai. You can use also adhesive from Ivoclar, also ART bond from Cotin. It's very good for this technique. By the way, it's based on this denting adhesive that was published, the article from Peter Scherer. So how do you do that? You dry denting. Do not apply acid. Apply the primer for 20 seconds and scrubbing, okay? Do not wash. Air dry for 30 seconds to evaporate the solvent. The air, the jet stream air should be like this. Not otherwise you may create bubbles inside the adhesive. Remember always, is to evaporate the solvent. Then you apply bond, light cure for 10 seconds each face. Put water-based glycerin gel, light cure for 10 more seconds each face. Wash the glycerin gel. So your denting is prepared and protected. Then you go just with a multi-blade bore and trim a little bit of margin. Just the margin, not the body of the restoration. Put the retraction core, clean the surface with a cotton pellet and alcohol. Take the impression. Work with temporary cement with free eugenol, with no eugenol in the formula. Okay? So you have to protect the dentin before you take the impression. Otherwise, you will not have margin adaptation. So this technique is to protect the dentin and also to increase the bonding strength when you do not have enamel. So the fifth step is impression and shade selection. I always work with addition silicone and or polyether with 2 retraction cords. I work the first cord is a 3-0 or 2-0 cord. This is from Pascal and another one from Ultradent. The second cord, Ultra Pack also, you can use the 0 or the number 1, 2-0 and 1-0 for the second cord. The first cord will remain inside the sulcus. Okay, I have already put the first. This is the second cord. I put it gently with a little bit of Hemodent. I like Hemodent for that. I put very gentle, respecting the biological width. Keep for not more than 5 minutes, okay? Then we remove a little bit the tip and start to remove. See that we remove the second cord, but the first cord keeps the sulcus open. Keeps the sulcus open for the penetration of the impression material. So we remove very gentle, okay, to avoid bleeding. See that? We wash. We have to be easy and calm. Wash with water before we do this to remove any hemodent that is inside the sulcus and dry a little bit. Then we start to inject the light material. See how the first cord keeps the sulcus open. Then we inject here. And then at the same time, your dental assistant is mixing the putty, putting in the tray, and you put in the mouth. Wait 5 minutes, some materials are 4, but always respect the manufacturer instruction. Don't go just with your hands or with your instruments. Wait for the time that is in the research, okay? Then we remove that. Sometimes the cord comes with the impression, but what's important, keep this cord in the impression. Do not try to remove, otherwise you may tear this. See that key? We have the sulcus here. The first cord has kept the space, and we have the margin of the restoration. Sometimes the cord remains inside the sulcus. That's all right, but don't take this one off. Leave it there. Just remove in the lab after you pour your cast. Lab communication, at least 2 pictures, one before, one after. One to see the final shade and another to see the base of the restoration. The technician knows how it's going to deal with that. Let's go to the temporary. We have many techniques to do temporaries for veneers. I will show how I did it for this case. I didn't cement this restoration because I have a lot of interproximal space. My preparation is enamel. It's not there's no denting, so no tooth sensitivity. So I just etched around area in the facial. Did not apply any bond. Just etched. Then I put Vaseline on the gingival tissue and the interproximal area, not over the tooth. Then I have a third silicone guide. I cut the silicone guide like that in the facial. And inside you cut here, in the interproximal area, to release this material. I do like 2 materials from this kind of technique. C-stamp from Ivoclar, and Luxatemp from DMG. It's called bis acryl resin for provisionals. It's not too rigid as a regular acrylic, for example, Duralate. Then you inject inside the silicone guide. Sorry, very gentle. You have time to do it. Then you go to the mouth and start to inject it close to the margin. Remember that you have Vaseline just at the gingival tissue. We start to put a little bit more than we needed and put the silicone in position. Do not press in the area of the veneer. Press in the posterior region. Otherwise, you will not have resin here in the front. We wait here like 4 minutes. It's very easy to work with this material. Then we start to remove, very gentle. Remember that we have Vaseline here, okay? So we don't have too much trouble. We remove it. See, it's almost done. For this technique that I did not cement it, do not try to remove. It's very thin. If you try to remove, to trim it outside the mouth, it breaks, okay? Keep inside the mouth. Then you go with a blade, remove all the excess from enamel, open a little bit here with a diamond bar, very gentle, and here we start to painting to be more natural. We use some Tetri color or any regular tint for resin. Photocure everything. This it's just for aesthetics and just for pictures also. You don't need to do every time also. This is just to show you how to do a nice temper, okay? This also may work as a simulation, a mock-up that the patient may see how it's going to end this treatment. Another trick that I give for you is for temporaries, work one of these sealers. You put it over the temporary and photocure. Make it much easier for your polishing, okay? Maybe Palasil, Varnish LC from GMG, Palasil from Kuzer, or Biscover from Bisco. Photocured, 10 seconds, put some glycerin gel, more 10 seconds. And then we have a temporary like this. The gingiva is not good, of course, because we did at same day, preparation, impression, and temporary. Then we sent to the lab. I will not speak about it, but here we did like 4 veneers and 1 small veneer just to give the patient a canine guidance. See the preparation in the cast. We did not remove too much enamel. It's just a slight reduction. See how it's important to cut this area. When you have to close diastema, I think it's better you prepare a little bit here. See? It's easy for insertion. It's easy for lab technician. It's easy for everything. It's easy for trying. You got a better margin adaptation. For this technique, I work the Emax press, the new ceramic from Ivoclar. It's a pressable ceramic associated with fluorapatite ceramic over it. And it's a ceramic that can be etchable. It's an etchable ceramic, sorry. So the 7th step is the trying and the adjustment. See, we remove the temporary, the gingiva is nice, we clean it with pomicin. We receive the veneers from the lab and check one by one the margin adaptation. And for it, I like to work with trying paste. Dr. Sadan, so that he works with water. It's a technique also, but I do prefer to work with a trying that I can see which the best shade for my resin cement. One of the brands that I like is Varlink from Ivoclar, okay? And you have also Varlink Veneer, when you have shades from low value to high value. And so you have like 6, 7 resin cements to pick, being one better than another, okay? Then you go to the patient's mouth. The trying has the same shade as the final resin cement. We try both. See that we have just a slight difference. When you go close, look, a little bit more value, a little less, but a little bit change, okay? He's a young patient, has a high value tooth. We go for the medium value. So the patient can see how it's gone. We check everything. We did not check the occlusion yet. We are going to check the occlusion after the bonding procedures. They max press, but you can do with any ceramic that it may be etchable, okay? A ceramic that you can etch it with hydrofluoric acid. This is a lithium-based silicone. And when you etch it, this ceramic, you have start with this surface. This is the inner part of the veneer before you etch it, and then after you etch it. Remember, you don't need to etch for more than 20 seconds. Depends on the type of your ceramic, you have a right time. You have a time to etch. For example, Empress 1, you just etch for 60 seconds. Empress 2 and Emax, 20 seconds. Regular ceramics, 2 minutes you can do it. It's different. It's not because the ceramic is has more resistance that you etch it more. For this ceramic, you just etch it for 20 seconds. After that, you cleaning, ultrasonic cleaning, wash, 5 minutes. Silane, 2 minutes. Some articles in the literature show that you need some heat for finishing the evaporation and reduce the contamination over the surface of the silane. So you put some hair dryer, okay, for at least 5 minutes. And then you put a hydrophobic adhesive. But do not photocure this adhesive. Keep it unpolymerized for cementation. Do not cure. Then we go for bonding. The veneer is ready for cementation. Let's go to the mouth. I always try to work with the rubber dam. It's make it much easier for me. In this case, it's a modified technique. See the preparation again. We have to go a little bit here inside to remove and to have emergence profile. When you have intact enamel, we should bond for at least 60 seconds, okay? So after 60 seconds, we dry the surface and have this image that everybody knows. And what's that? This is the surface. When you etch a surface, you destroy a little bit of the surface, creating a space for the resin to penetrate, becoming a bonding interface. We go one by one. Do not etch or do not do all the cementations at once. Just do one by one. Perfect? For enamel, you have like a hybrid layer of around 10. So that etchables, that surface that has been etched has around 10 micrometers that will be penetrated by the bonding agent. Here's the hybrid layer that you have in enamel. Just go one by one. Here, I did not use cord, okay? But it's possible to work with core during cementation. Sometimes when you have the preparation almost inside the sulcus, it's better to put the retraction core that make it easy for cleaning and for polishing procedures. Then we finishing, cemented all the 4 veneers and 2 small pieces of ceramic here. Some people like to work to remove the cement with burrs, diamond burrs, or even multi-blade burrs. Do not do that. I strongly recommend that we have to try to protect this area that we have just bonded. In facial area, it's better to work with a blade. For example, this one, very gentle, okay? And remove with a sandpaper sometimes. See that imaging, why is important for us to avoid burrs. This is an in vivo SEM. I did in my own patient. This is a second premolar. I finish, I grab a diamond burr, very fine burr, ultra fine, for finishing the margin. And here you see that even with very careful procedure, we never polish it again. So every time that you put your diamond burr, no matter if a fine, extra fine, you will always scratch the surface. And if you have an interproximal area, you will never polish it again. So try to do not do these kind of things in the facial, mainly in laminated veneers. Of course, there's only, no one will see, even you, but you have it. If you put the burr, it's almost impossible to polish again. Not in the occlusal surface, but in the area close to the tissue. So we have this kind of result just after the cementation. This was for enamel. And now, a little bit back, if you have denting. Remember that we had denting. We protect denting with the adhesive. Now we remove the temporary, clean the surface. Okay, this is another case. No matter it's veneer or a crown. Clean the surface. I do like to work with chlorhexidine gel and pumice. Clean very well. Remember, this denting is protected. We just do the trying, the adjustment. And then you may go for final bonding with phosphoric acid etching protocol. I mean, the regular protocol. You just etch the surface for 5 seconds, but it's not for etching, it's for cleaning, because your denting is already protected. So this technique, as I mentioned that articles, is called immediate denting sealing. I do it in every vital tooth for more than 10 years. I had avoided a lot of root canal treatment. And always I'm doing most conservative preparations. So what the advantages of this technique? You reduce the tooth sensitivity, okay, because you protect the dentin just right away. You improve bond strength. Remember the 3 articles that I've mentioned at the beginning? When you have dentin for veneers, you have decrease of the success rate. It's important. If you do not have enamel for bonding, protect the dentin before you take the impression. We have 10 years experience, and we have, if you go to the literature, you'll find articles from Pascal Money, Peter Sharon, Stephen Pohl, David Peshley, Nikaido from Japan. In every place of the world, we have research regarding this technique. I think it's a very safe and important technique for prevention. Also, You have better sealing during temporary phase, because if you have denting exposed to the mouth or even to the temporary resin, the temporary cement, it's not good. So if you have the boning agent over there, it's better. And you avoid also this contamination because you have everything protected at the beginning. Then we go for finish and polishing procedures. I like this too. This is from Edenta. It's a Swiss brand. You have two types of rubber for ceramic. And intraoral, I do like this material named Ultrafine from Ivoclar, that you have two rubbers and in one paste for polishing veneers, inlays, onlays, and so on. The clinical control, if you go to the literature, you see 10 years, 5 years, 15 years laminated veneers, success rate. But what's important for us? Remember always, stable occlusion, bonding procedures, strictly follow, let's follow the protocol always. And here, 6 months after we finish the restoration, we see how stable is the tissue. You see here the emergence profile, remember? Remember always that many authors have mentioned sometimes that retraction cord cause recession of the gingiva. It just happens when you do not how to deal with the gingiva. You have to understand what is biologic width. We have to understand how the tissue will respond to this aggression. We have to be very careful when we do technique for impression that work with two cords, but see the results after 6 months. Okay? Then the final restoration. This case were done with a technician in Brazil named Paulo Batistella. He works with a lot of ceramics. This case we did with Emax press and Emax run. So to finalize the case, I'd like to give to you 4 issues for thinking about it. Clinical examination is very important. See what the patient wants. Be careful with the patient. See what they want, okay? Also, occlusion is very important. Don't do veneers in patients with occlusion problems. Do a careful analysis of the occlusion pattern of the patient before you do laminate veneers. Respect the perio architecture. Respect it. Respect the biological width. Know the material that you use. Work with digital photography. Nowadays, it's impossible for a dentist who works with aesthetics implants does not have a camera. When I speak about a camera, it's not just a regular camera that you take picture of for kids. It's a semi-professional camera with nice flashes. We have to understand light. We have to understand how to work with photography. And it's very good for us because we learn doing it. The treatment planning and the clinical sequence. Before you do the after you do the treatment planning and before you touch the patient, put the clinical sequence in your mind, step by step. Thinking always how it's going to end, respecting always natural dentition. When I say protect natural dentition, it's not because you are a prosthodontist that you have to destroy a tooth. You may do conservative preparation for veneers, for onlays, for crowns, for fragments, for any kind of ceramic that you can etch and bond to dental structure. So let's always keep your eyes open. When I say open, because many times we see nice cases in the screen, but all of us has failures. Not all the cases became perfect. Sometimes we made mistakes, but we have to know how to correct these mistakes. And once more, work with digital photography has helped me a lot. Some case, the patient came to me after 5, 6 years. I went back to my slides 10 years ago. I take pictures and compare. Oh, okay, this preparation is not too bad, but can be better. I start to compare my cases. I don't need to show the patient if it's good or not every time. Sometimes a small recession happens. It's biology. If you go to the beginning of the lecture, one of the articles that I've mentioned, recession happens in tooth and in laminated veneers tooth also. In both, there are teeth. So, let's keep our eyes always open, because when we try to open our eyes, we start to understand how do you do mistakes. How do you see your pictures? So you have to, by looking for details of our own work, sometimes we feel disappointed, sometimes encouraged. But open your eyes, encourage us to improve our quality day by day, not only for us, but for our patient. Keep your eyes always open, work with photograph, thinking about the patient, thinking about biology. That's what I believe. I'd like to say thank you everyone for your attention.